This morning, I am very happy and pleased to introduce Dr. Ann Maitland, who will be doing our grand rounds this morning. Dr. Maitland is an assistant professor here at Mount Sinai in the Division of Allergy and Immunology, and she's the medical director of the Comprehensive Allergy and Asthma Care in Tarrytown, New York. She earned her MD PhD from the University of Pennsylvania in Philadelphia. She did her residency at Brigham and Women's Hospital, and then her Allergy and Immunology Fellowship also there, as well as Mount Sinai Hospital. She is a fellow of the American College of Allergy, Asthma, and Immunology, and currently serves as the vice chair of their Mast Cell Disorders Committee, as well as chairs the subcommittee for Patient-Centered Outcomes Research Institute for patients diagnosed with Ehlers-Danlos syndrome. She is a former past chair of the Committee for the Underserved of the Society, and is also a faculty member of the Allergy Immunology Division of the NME Association. She has a clinical focus on upgrading the efforts to meet the needs of underserved communities plagued by occupational immune-mediated disorders, asthma, food insensitivities, and primary immunodeficiencies. She's been named one of the New York Times Super Doctors since 2012, as well as the Casa Cannoli Top Doctors, the Westchester Magazine Top Doctors, and one of America's top 21 women's doctors by LifeScript in 2009. We are really thrilled that today she'll be here to talk to us and enlighten us on the good, the bad, and the ugly of mast cell activation. Thank you so much for joining us, Dr. Maitland.
It's my pleasure. Thank you for the honor of talking about something that has really come to the forefront in redefining how immune responses become aberrant in disarray. So let me see if I can share my screen. Okay. Perfect. All right. So I have to say that most of us probably had about 1 or 2 lectures first year of medical school on mast cells. So I'm just going to do a little bit of an introduction about this tissue-based innate immune cell, and then how it's been coming to the forefront and understanding the pathology of delayed and immediate hypersensitivity disorders. So these are my disclosures, and there are no conflicts of interest during this lecture. So this is just the overview. We're just going to be talking about mast cell activation disorders, including MCAS. That MCAS endotypes are more than just allergic inflammation. And then it's important to understand what type of trigger or triggers may be causing the mast cell compartment to be dysregulated, which will then dictate more appropriate and effective therapeutic options. So mast cells were originally described back in 1863, and I have to say, really, we did not assign a job to this tissue-based immune cell until 1989, when it was identified that serum immunoglobulin on top of mast cells were responsible for contributing to the growing epidemic of immediate hypersensitivity disorders such as asthma, food allergies, and anaphylaxis. I would like to point out that the original identification of these cells were found in frogs. They've also been identified in shellfish, birds. This is a very old cell that seems to play a key role in lots of functions in the body, and we're just starting to appreciate how this might be manifesting in tissue injury, tissue inflammation, contributing to autoimmune and immediate hypersensitivity disorders. So I would say back in the 1950s is when we started to see a serious increase in immediate and delayed hypersensitivity disorders in the wake of a lot of modern miracles, including tackling several infectious diseases, although COVID is now redefining that. But nonetheless, it was in the 1980s where we really started to see asthma on the rise. Interestingly enough, Ed Koch in New York was about to declare asthma as the #1 public health enemy until over 600 men died from AIDS infection. So we're starting to see huge numbers of hypersensitivity disorders. These are the classic presentations of mast cell dysregulation per organ system. Rhinitis, interestingly enough, is the #2 reason for absenteeism from school as well as work. We have 1 out of 5 individuals at one point in time will have this mast cell-based skin disorder, and what's most concerning is the last report regarding anaphylaxis in America identified that 1 out of 50 have been treated for anaphylaxis or carrying an epinephrine autoinjector due to their risk of having anaphylaxis. But I also want to point out that mast cell dysregulation can occur in any organ system. And one of the studies I'm actually going to talk about that describes the first series of mast cell dysregulation was actually in the gastrointestinal tract, which was a joint effort between the Gastroenterology Division and the Allergy Immunology Division of Brigham and Women's Hospital. So before 2010, when somebody was having hypersensitivity reactions, we either did allergy testing, and if the allergy testing was negative and the person was still having complicated hypersensitivity reactions, we suspected a very rare clonal mast cell disorder called mastocytosis. The top right is indicating the classic derriere sign when you strike these mastocytomas in the skin called Urticaria pigmentosa. But the individuals that were focusing on evaluating individuals for possible systemic mastocytosis started to realize that there were a growing number of children and adults that were experiencing hypersensitivity reactions that neither allergy testing or as our systemic mastocytosis or urticaria pigmentosa would explain. And this is again highlighting the fact that immune-mediated disorders through the mast cell compartment may be impacting at least 40% of the population at one time or another. So in 2019, the American Academy of Asthma, Allergy, Immunology put forth formal proposed criteria to describe how someone might be having or describe what might individual be experiencing if they have mast cell activation syndrome. And it really is a rule of 3. Are they having signs or symptoms that are recurrent in at least 2 or more organ systems? And I'll talk about the systems that are the common presentations, but again, mast cells are in every single organ system, so dysregulation can cause pathology anywhere in the body. With these symptoms, are you able to just capture an increase of mast cell mediators? And understand these are pretty potent chemicals, including histamine, tumor necrosis factor, interleukins, as well as enzymes such as tryptase. And then the third criteria is, do you respond to medications that are known to particularly stabilize the mast cell or antagonize mast cell-derived mediators? And if you meet these 3 criteria, you have met the diagnosis of mast cell activation syndrome, which is basically saying that your mast cells are misbehaving. So this is again just summarizing what it looks like when I'm trying to evaluate somebody who has a suspected mast cell disorder. Signs or symptoms including rhinitis or gastrointestinal distress, interstitial cystitis or pain syndromes, neurocognitive disorders and headache syndromes. Skin manifestations are quite common, and I'm about to show you that one of the most common phenomena presenting is if it's not the skin, it's the gastrointestinal tract that seems to force patients to undergo evaluation. Do you get better with medications that target the mast cells, such as over-the-counter H1 and H2 blockers? And then again, what test results do you have to support that your mast cell compartment is dysregulated? So this is a study that was done between Matthew Hamilton, Norton Greenberger, Marianne Canessels, and Ken Aiken at Brigham and Women's. And what they did was they went into the IBS clinic at Brigham and Women's and did a prospective study asking individuals, do you have signs or symptoms worrisome for mast cell dysregulation outside of the gastrointestinal tract? In a 2-year period of time, they identified 18 individuals. And what they did was they went ahead and did targeted mast cell activation syndrome markers. This includes the most specific one, which is serum tryptase. And I have to tell you at this point in time, we don't know what a normal tryptase is. And I'll explain that a little bit more. But other markers that are also might point to the mast cell compartment being dysregulated is serum histamine, plasma, 24-hour urine collection for N-methylhistamine, as well as the prostaglandins. And unfortunately in New York, we're only able to do the prostaglandin test as late as 2017. So this test has only just become recently available in New York State. But these are the signs and symptoms that they would look for beyond the gastrointestinal tract. And again, you can see that dermatographism, which is a non-immunologic trigger of mast cell degranulation in the skin, as well as flushing, were a common presentation in these patients that were identified. Right after GI distress and skin symptoms, it was actually neurocognitive issues. Headache disorders, brain fog were also common complaints in these patient population. What I would like to point out, though, is these individuals were in the IBS clinic for an average of 5 to 6 years. And until they were asked these questions, their medical regimen wasn't changed. And when it was changed to a combination of cetirizine and ranitidine at the time, 80% of the patients noted complete or moderate to complete resolution of their symptoms within 2 weeks of starting a new regimen. So I would ask that in your patients that are complaining of irritable bowel syndrome, it would be important to identify whether or not they have signs or symptoms of mast cells being dysregulated outside of the gastrointestinal tract with some simple questions. Have you ever been treated for allergic rhinitis? Are you carrying an EpiPen for anaphylaxis? Do you have a headache disorder? And then it'd be worthwhile to try to evaluate with this type of testing whether or not these individuals have a dysregulated mast cell compartment contributing to their IBS symptoms. So these are two of the studies looking at the signs or symptoms of mast cell activation syndrome, and understand individuals that have systemic mastocytosis don't necessarily have aberrant mediator release. But in this cohort of 400 patients, you can see that skin and gastrointestinal tract were the leading symptoms that caused presentation to the mastocytosis clinic. But right after that is neuropsychiatric. The same in the non-clonal mast cell activation syndrome cohort, and this is the study that I just talked about, where again, GI distress, skin, and then neuropsychiatric are also common manifestations in individuals that have mast cell activation syndrome or mast cell activation disorders impacting more than one organ system. Then when it comes to testing, these are the tests that I typically do to, or have been done to reevaluate whether or not they have dysregulated mast cells contributing to their symptoms. So regarding a serum tryptase, we actually do serial measurements. We get a baseline, and then if someone has an exacerbation, they have a script to check their tryptase within 4 to 6 hours of that exacerbation. And I have to tell you that the emergency department at Mount Sinai really has embraced this evaluation. We've been able to identify individuals checking a test that is not standard in the emergency department. We also check for plasma histamine and 24-hour urine collections for histamine. Again, we're now able to check for prostaglandin metabolites, including PG2 and PG2 alpha, 11 beta, PGF2 alpha metabolites in the urine as well. But actually the gold standard to try to identify whether you have mast cell dysregulation is actually to look at the mast cells in the tissue that's impacted. And I can't tell you how many individuals who have undergone endoscopies and colonoscopies, if we go back and stain the tissue looking specifically for mast cells using either anti-CD117 or anti-tryptase. And I'm going to talk about a case report of a gentleman who had 2 endoscopies and was quite symptomatic and was found to have a mast cell activation disorder. It was the increased presence of activated mast cells that confirmed the diagnosis of mast cell activation syndrome. And then these are some of the medications that we have used to try to treat individuals that have mast cell activation syndrome that's not complicated with another overlooked disorder. And so again, you have the histamine blockers. You have first, second, and third generation H1 blockers. You have H2 blockers. And I have to tell you, we use quite a bit of tricyclic agents. It was interesting that tricyclic agents were the first set of pharmaceuticals that were used for mood disorders, but as SSRIs came into the psychiatrist's handbook, tricyclics were essentially dropped, and it was picked up by allergy immunology specialists for chronic urticaria. Gastroenterologists use it quite a bit for IBS-like symptoms, and neurologists use it for pain syndromes, and that's because the tricyclic agents actually hit on H1, H2, and H3 antagonism. You also have the leukotriene antagonists, which are commonly used for rhinitis as well as asthma. There are mast cell stabilizers, including catodafin and cromolyn. Corticosteroids are not as specific for mast cells. They can impact other cell populations. The use of acupuncture and acupressure by Schumann Lee prior to leaving Mount Sinai has also been shown to be quite effective for trying to control some forms of mast cell disorders as well. I want to remind you that not all activation events with mast cells involve histamine or tryptase. And this is showing the difference in the signaling cascade at the surface of the mast cells. So if you engage mast cells through the toll-like receptors, you can see that there is no release of proteases or histamine. This is actually, you can actually have anaphylaxis through the toll-like receptor as well, just to highlight that. But if you do indirect activation of mast cells, either through the complement cascade or through immunoglobulin receptors, you can see and then also potentially detect the release of proteases or histamine to confirm the diagnosis of mast cell activation syndrome. So there's lots of different ways to tickle mast cells for aberrant release of these chemicals, excuse me, which are quite potent. And can have local as well as systemic wide effects. So this is again to summarize the cheat sheet to identify and determine whether or not someone has mast cell activation syndrome. Do you have signs or symptoms worrisome for recurrent hypersensitivity reactions in 2 or more organ systems? Does the patient feel better if they take a combination of an H1 and H2 blocker? And then after getting a good history, do you have lab results that suggest that the mast cells are the culprit of their hypersensitivity or their symptomatology as well? Once you get the diagnosis or suspect that someone has a mast cell activation disorder, it's really important to sort out what form of mast cell activation disorder they are, and I've broken it down to clonal versus non-clonal. Or essentially, is there an intrinsic defect in the mast cells that's causing a subset of mast cells to misbehave, or are there outside triggers such as having allergen-specific IgE, having autoantibodies that recognize either the thyroid, or we actually have quite a few patients that have multiple sclerosis that also exhibit mast cell activation dysfunction. Physical urticarias, where there seems to be a miscommunication in the connective tissue between the peripheral neurons as well as the mast cells, which crosstalk all the time. And then within the past 15 years, Greaves and his colleagues have identified the fact that mast cells can also be the target of an autoimmune phenomena with either antibodies targeting the Fc receptor or the Ig molecule itself. And more recently, Josh Milner, who was at the National Institutes of Health and now is the director of the Allergy Immunology division at Columbia Presbyterian, identified that in addition to seeing mutations in the c-KIT gene, he was able to identify individuals that have hypersensitivity syndromes where they have multiplication of the tryptase gene. And this test, looking for duplication or triplication of the tryptase gene, is now available in New York. It's performed by a company called Gene by Gene. And after you've done all of the testing that is available, we actually do have some individuals where we need to figure out a little bit more what might be going on with them, and they're labeled with either idiopathic anaphylaxis or idiopathic urticaria. So this is an interesting article that was in the Lancet in the 1950s talking about the riddle of mast cells. And I would have to say that most efforts have focused on allergen-specific IgE degranulation. As a matter of fact, 90% of grants that are awarded through National Institutes of Health focus on atopic disorders. But mast cells are intricately involved in several forms of homeostasis, including tissue maintenance, tissue defense. They're able to release platelet-activated factor and heparin, as well as prostaglandins that can alter blood flow. And they also seem to play a key role in reproduction, which is quite evident in women that have atopic disorders who find that their hypersensitivity disorders get worse with the onset of menarche or onset of menopause, or even as they cycle on their monthly period. But I also wanted to point out that there's several receptors on the mast cells, and depending on what receptors are engaged, you'll have a different set of release of chemical mediators based on what the cells are seeing. So for instance, if you engage a virus or a bacteria through the complement receptor, you're only going to be releasing histamine proteases as well as chemokines that might recruit in other cell populations. With venoms, you actually have the release of enzymes that actually can degrade these toxins and deactivate them. And this is quite evident if you ever watch a video about a honey badger who goes up against a very poisonous African snake. They can actually kill the snake and survive a sting or a bite from the mast cells as well, from the snakes as well. We also have the role of mast cells in tissue repair. And so it seems that the close relationship of mast cells to the epithelium will influence the mast cell function. And there's growing evidence showing that chemical messengers derived from the epithelium, including TSLP, interleukin-33, will influence the ability for mast cells to become activated. And this will also come into play in trying to understand the role of autoantibodies or allergen-specific IgE. Not everyone who has positive antibody tests are actually symptomatic, and what might be determining whether you're symptomatic or not is the interaction of the mast cells in the connective tissue as well as with their association or communication with the peripheral nerves. So in many ways, because of their strategic location with the barrier, these long-lived mast cells have the ability to instantly release signaling substances that can influence the local tissue as well as recruit in other factors, including complement, innate and adaptive immune cells in order to respond to the tissue injury. And in addition to performing tissue surveillance and defense to some of these insults, whether immunologic or non-immunologic triggers, we also find that mast cells play a key role in coordinating vasodilation and vasoconstriction, which plays a role in tissue repair as well. So these cells have to be tightly regulated, again, highlighting all the different types of chemicals that they can release depending on what the triggers are. And I want to highlight that when it comes to identifying mast cell activation syndrome, we're focused on looking at tryptase, histamine. Heparin is very difficult to measure, so there are some investigators recommending measuring heparin, but this has not been shown to be associated, nor measuring chromogranin A has been helpful in identifying individuals that have mast cell activation syndrome that would actually respond to some of the treatments that I'm about to talk about. So I just want to indicate all the different type of triggers that can happen with mast cell activation. This is just to give you a list of what we try to investigate when somebody comes in with chronic urticaria. You can see depending on what receptors are engaged by what insults will lead to urticaria in the skin or angioedema. The same thing for anaphylaxis. This is a recent article by Mariana Castells that shows that you can have anaphylaxis through more classic type 1 responses, whether you're involving IgE or non-immunologic triggers. We have the ability, and we see this quite a bit with individuals who receive antibodies for neoplastic processes, where we actually see a form of anaphylaxis that just involves tumor necrosis factor, interleukin-6 and interleukin beta. And these individuals typically will have constitutional symptoms along with signs of anaphylaxis with cardiovascular compromise. We have some individuals that have a mixed phenomena where we're actually not only involving the mast cells, but basophils can be also involved. And then we also have complement-mediated anaphylaxis as well. So when it comes to determining whether or not somebody has a mast cell activation disorder, it's equally important to understand what might be causing the mast cells to be dysregulated. And then this is again summarizing the fact that it seems to be injury to the epithelium that leads to dysregulation of the mast cell compartment. It's a model that's based off of a theory put forth by investigators regarding the danger theory. So it is tissue injury, and there's different types of injury versus apoptosis versus necrosis that will then lead to unleashing the ability for mast cells to release these very potent chemicals. And some of the endogenous self-alarm signals include bacterial products, include the release of heat shock proteins, interleukin-1, as well as having direct cell-cell contact with activated T cells. And what's interesting is I'm actually going to briefly talk about some work that we identified, individuals that were being evaluated for suspected mast cell disorders, and they were actually found to have idiopathic CD4 lymphocytopenia. So in many ways, individuals that have either cutaneous signs or gastrointestinal signs of mast cell dysregulation, more than likely this could be a canary in the mine of an overlooked, undiagnosed chronic disorder, such as immunodeficiencies, a connective tissue disorder, or a autoimmune phenomena. So again, this is kind of highlighting the different mast cell phenotypes that have been identified over the past few years once the proposed criteria were put forth. In my practice, we've identified, out of the 1,000 people that we've evaluated over the past 5 years, less than 10% have been identified with either mastocytosis or a minor form called monoclonal mast cell activation disorder. More than likely, if a person has mast cell activation syndrome, it's secondary to another process. And most of the efforts of our practice has been trying to identify what that secondary process is. These are some of the tests that I perform. We definitely look or review allergy testing, which typically has been performed before. We have a tendency to contact the gastroenterologist and the pathologist to say, can you please go back? We have, the stains that are being used typically will highlight eosinophils, but again, you have to use very specific stains to identify mast cells. And not only should you identify the mast cells, you should actually use activation markers such as CD2, CD25, and CD30 to see whether or not the mast cells are chronically activated. We also do an evaluation for primary immune deficiency, looking for whether or not you have the full complement of antibodies, adaptive immune cells, or immunoglobulins as well as complement. We do rheumatological surveillance as well. And then we also starting to actively do screening for connective tissue disorders. There's emerging evidence suggesting that individuals that have connective tissue disorders such as Loeys-Dietz, Marfan's, as well as Ehlers-Danlos variants are much more at risk for having dysregulation of the mast cell compartment. This is just a table illustrating the different forms of mast cell activation syndrome, meaning that you have an intrinsic defect, you have mast cells responding to an outside trigger. I have to tell you that the mast cell activation syndrome associated with hyperalpha tryptacemia was only identified in late 2016, and this is an autosomal dominant inherited pattern. And according to Dr. Milner, it seems that this was a selective advantage until the world changed and became quite modernized with increased exposures to chemicals that the epithelium was unaccustomed to. And then if you can't identify either a primary or secondary mast cell disorder, they fall into idiopathic anaphylaxis. The fourth hidden criteria is to make sure that you're not missing any other conditions. Again, mast cell activation syndrome is being assigned to patients with very vague symptoms such as abdominal pain, fatigue, and wasting syndromes. Again, it's important to try to highlight whether or not there might be other phenomena going on. If this is a list that I'm happy to supply my slides so you'll have it. And then there's some good review articles that also highlight other conditions that can be a mast cell activation syndrome masquerader. So I wanted to kind of just go through two cases to try to illustrate how these patients present. No one has a sign over their head saying that they have mast cell dysfunction. This is one of the first patients that had kind of forced me to rethink my knowledge about mast cell disorders. I'm a T-cell biologist by training. And this was a gentleman that was referred from the endocrinology department. He had had a history of asthma and was hospitalized in 2012, interestingly enough, for alcohol withdrawal. He had become sick, had stopped having his daily glass of wine at dinner, and then literally went into withdrawal where he was only responsible to a Valium taper to control his flushing gastrointestinal distress, and actually had to require oral steroids to control his asthma. His past medical history is actually quite interesting. He actually received immunotherapy for venom anaphylaxis, although he was seronegative on 3 different occasions. He stopped immunotherapy for his stinging insect allergy a few years prior to this evaluation. He also was diagnosed with a right bundle branch block in his 30s and had a completely negative cardiac workup. I have to tell you, there was a gentleman named Dr. Kunis who identified individuals that actually have vasospasms of their coronary vessels in the setting of an allergic response. And so he actually may have had what was called a quote-unquote allergic heart attack that caused him to be dependent on metoprolol because of his development of the right bundle branch block. And then in 2007, he had undergone evaluation by several different disciplines for ongoing eosinophilia, which seemed to spontaneously resolve a year prior to his presentation to our practice. So we actually talked to his gastroenterologist who had been evaluating him for the eosinophilia and asked him to go back to his endoscopies. And thankfully, most of the tissue had been retained. And the gastroenterologist had identified that he had anywhere between 25 to 50 mast cells per high power field, depending on where we were looking. And he actually had undergone a workup by Dr. Warner for carcinoid, which was also completely negative as well. So these are his physical exams. He was still quite flushed. Otherwise, cardiovascular and respiratory-wise, he was quite normal. His spirometry did reveal still an obstructive pattern of asthma, suggesting that it still was not well controlled. And we did do skin testing. Even though he had a very low serum Ig level, you can see that he was positive to ragweed and alternaria. He still had eosinophilia, which might have been associated with his serum Ig, his allergen-specific serum IgE to ragweed, because when we evaluated him, it was actually in the fall. But what was interesting, and it was called normal, was his tryptase of 15. Now, he was lost to follow-up 4 years ago, prior to the report on hyperalpha tryptacemia. But interestingly enough, he did undergo an evaluation for mastocytosis, which was completely negative. So I suspect that this gentleman actually has either a duplication or triplication of the tryptase gene, meaning that his mast cells in the granules have 2 or 3 times as much tryptase. And so upon degranulation through certain pathways, he can actually end up with anaphylaxis, which I think was happening when he tried to reintroduce wine after his illness, and he actually had anaphylaxis to a non-immunologic trigger, the alcohol, upon ingestion. So this is to kind of talk about hyperalpha tryptacemia. This was identified by Josh Milner and Jonathan Lyons back in 2014, and this is the genetic study that came out in 2016. What's really interesting about this duplication, triplication, and in some cases quadruplication of the tryptase gene, it's associated with these 3 conditions with differential penetration. So these individuals would complain about irritable bowel syndrome. They would have cutaneous complaints such as flushing, urticaria, and sometimes angioedema. They all had connective tissue issues, either hypermobile spectrum disorder or hypermobile Ehlers-Danlos syndrome, and they all had variable complaints that were worrisome for autonomic dysfunction as well. So you have a mutation in a innate tissues mast cell that is responsible for impacting 3 different organ systems. And this really has been an eye-opener trying to identify the role of mast cells in homeostasis and aberrant mast cell activity contributing to different forms of pathology. So I want to talk a little bit about one of the more common mast cell disorders, and that's chronic urticaria. And this is a patient that had come to me. I was allergist number 5, who had had chronic hives for years. And as you know, our healthcare system is quite fragmented or segmented, that individuals will go to the specialist that they think is their best source of trying to figure out what's going on. And so she had been through various H1H2 cocktails is still quite persistent. But then with her review of systems, she also had a headache disorder. She had been treated for mood disorders, including depression and anxiety. She reported episodes of irritable bowel syndrome and stopped going to the gastroenterologist because the use of medications at the time, such as Linzess, was not helpful. She had episodes of dizziness, which was worrisome for orthostatic intolerance, and again, she had a sleep disorder. This is some of the labs that she had. You can see that her CBC with diff was really unremarkable. Her serum Ig level was also unremarkable. But she still was calling complement in from the liver. Even with an IgE of 9, you can see that she actually had quite a few allergen-specific immunoglobulins, so she almost was like a sharpshooter with her IgE in recognizing these perennial and seasonal allergens. And then we decided to do some more specific testing for mast cell activation syndrome. So first of all, her thyroid functions were normal, but she did have a positive antibody against the mast cell itself. So we were able to detect an IgG against her Fc receptor, epsilon receptor on her mast cells. Again, and then her tryptase was also quite worrisome in that, in that this level of 9.3, and understand I evaluated her in 2016, but in 2017, Dr. Milner and Dr. Lyon said if you see a serum tryptase of 6 or higher, it would be worth looking for that multiplication of the alpha tryptase gene. But what was more important is that she had a serum IgG level of 532. And on review of her systems, she had been getting antibiotics at least 3 to 4 times a year, either from her pulmonologist for asthmatic bronchitis or her gynecologist, which unfortunately a lot of women use for their internal medicine care. And no one seemed to understand or look into why she was having these infections. So in many ways, her mast cells were being tickled by lots of different things. So she had hives and flushing, she had neuropsychiatric illness, she had gastrointestinal distress. So there are her 2 or more organ systems. She had a tryptase of 9.3. She was lost to follow-up, but it would be interesting to see whether or not she had hyperalpha tryptacemia. She had we went back to an old EGD biopsy sample, and again, she had more than 40 mast cells per high power field. And I have to tell you, this is literally what her comment was when I first met her. She just said, my life is heck, 24/7. Even using all of these medications, including first and second generation antihistamines, and receiving corticosteroids with her asthmatic bronchitis flares. So the type of treatment that we ended up using really focused on her recruitment of the mast cells due to her immunodeficiency. So she actually did quite well with azithromycin. So for individuals that have hypogammaglobulinemia, you don't necessarily need to go straight to IVIG. So we did azithromycin prophylaxis starting in September through February, where we see a huge increase in infectious triggers of sinus disease as well as asthmatic flares. We continued her with her histamine blockade in order to reduce her dependence on corticosteroids. And we put her on Anterogam, which is essentially IgG used for IBS, but her IBS was actually in the setting of her having hypogammaglobulinemia. And after she had received, we had to stop her azithromycin and did 2 more courses of oral antibiotics because she broke through the prophylaxis. We did start her on IVIG, and interestingly enough, not only did her urticaria improve, her GI distress improved, her neuropsychiatric issues also showed better control. So for her, it's really important, or for patients that you have a suspected mast cell disorder, again, depending on what might be causing the mast cells to misbehave, that they have an intrinsic defect or they have some type of secondary disorder that's driving the mast cells to misbehave, your treatment options are going to focus on what is tickling the mast cells. So if they have allergen-specific IgE, these are the recommendations. As far as anti-interleukin monoclonal antibodies, there are 3 available now. So you have an anti-interleukin 4, anti-interleukin 13. You have anti-interleukin 5 that's being used, especially in individuals that have eosinophilic gastrointestinal disorders. This is an upcoming therapy that might be very effective. You have omalizumab, which actually targets the IgE FC portion of the IgE molecule as well. If there's autoimmune disorders, again, you have a plethora of anti-inflammatory agents, and you want to tailor it based on risk-benefit with the medications itself. IVIG and subcutaneous gamma globulin are used for autoimmune disorders such as multiple sclerosis, and I have had it approved for immune-mediated neuropathies as well. As far as connective tissue disorders, interestingly enough, physical therapy along with traditional Chinese herbal therapy has been shown to be effective. This is some of the work that Xiumin Li has done at Mount Sinai and now has continued at Westchester Medical Center, New York Medical College. If they have a primary immune deficiency, and understand individuals that have primary immune deficiencies are also at risk for autoimmune disorders just as much as that they are at risk for recurrent or severe infections. You again have the use of prophylactic antibiotics or immunoglobulin supplement as well. I just want to talk about some of the conditions that have been identified in individuals that come for an evaluation for mast cell disorders. One of the more common manifestations is actually disorders of the autonomic nervous system, including postural orthostatic tachycardia syndrome. There's been plenty of data coming out of the neurology world trying to understand the role of mast cell dysfunction contributing to cardiovascular capacitance. And so these are some of this is common presentations that typically are female more than male. Most individuals, the study that came out of Children's Hospital of Philadelphia, the POTS program there, they had noticed that a lot of the patients would be suffering for an average of 3 to 4 years before a diagnosis. When they were given medications that targeted the cardiovasculature, they also seemed to improve with the use of medications that targeted the mast cell compartment as well. Some of the work that we've done in our practice was to identify that mast cell activation may be a presenting sign of an undiagnosed primary immune deficiency. We've been basically taught these 10 signs of an individual that may have primary immune deficiency, including recurrent upper respiratory infections, organ abscesses, the need for IV antibiotics to clear infections, and this is separate than individuals that are being empirically treated with IV antibiotics for parasitic infections such as Borrelia and Bartonella. If they've had a history of pneumonias, I have to tell you, when I was a fellow with Charlotte Cunningham Rundles, we had one person who was with a pulmonologist for 15 years out of Philadelphia. And until that pulmonologist retired, the new pulmonologist is like, it's not right that you're getting 1 to 2 pneumonias a year. It turned out she had common variable immunodeficiency. If you have an adult or an infant that has failure to thrive, it would be important to see whether or not they have primary immune deficiency as well. What we've identified is individuals presenting with hypersensitivity disorders, and they end up having deficiencies either in the innate or the adaptive immune compartments. To this point, and this is an old report, I apologize, I didn't have time to update it, we have now identified 17 patients who are presenting with hypersensitivity symptoms, as you see displayed, who actually have a CD4 T cell count below 400. And this has consequences not only with recurrent insidious infections, but also hypersensitivity infections as well. We've also identified individuals with mannose binding lectin, common variable immunodeficiency, selective antibody deficiencies. So it's important to understand that there is a constant crosstalk between the adaptive and immune innate compartments. The mast cells seem to dictate what kind of adaptive immune response will be important, and I would emphasize it'll be interesting to see. There's emerging data now coming out on the role of mast cells in dictating the type of immune response to coronavirus as well. In individuals that have connective tissue disorders, this is data from Mark Castori, who's a geneticist. He had suspected in 2012 that there are manifestations to joint hypermobility other than musculoskeletal symptoms. He had put forth that there seems to be immune dysregulation. I would argue that the immune dysregulation in a connective tissue disorder would be the cell that is closely associated with the epithelium, and that is the mast cells. We have data showing that individuals that have the diagnosis of hypermobile spectrum disorder or hypermobile type Ehlers-Danlos syndrome are at increased risk for having dysregulation of the mast cell compartment. And they also have a tendency to be complicated with other immune defects, including poor production of immunoglobulins. On average, they have 1 to 2 standard deviations below the mean for IgG production and have compromised ability to make antibodies against organisms such as Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. So this is to, again, summarize how to suspect someone that you might be seeing with irritable bowel syndrome or gastrointestinal distress. It would be important to do a review of symptoms, and if they check off they have treatment or are complaining of upper respiratory symptoms, if they have interstitial cystitis, if they're suspected of having arthritis, which is serologically negative, for instance, it would be important to see whether or not they have a mast cell disorder. Please, it's important to look for, and also ask them, have you tried Benadryl over the counter, or have you tried Zyrtec or Loratadine, to see whether or not that's important. And you'll be surprised that they say, yes, I do get some relief, but as soon as I stop taking the medications, they relapse. And then you can do appropriate testing, at least to screen for the possibility of a mast cell disorder by checking serum tryptase or a plasma histamine level. Anything more than that, you have plenty of allergy immunology colleagues at Mount Sinai, one of the few centers in the country that has in-house adult allergy immunology at your disposal. Again, these are some of the syndromes that are typically associated with mast cell activation syndrome. Just to kind of go over some of the testing, this is reiterating what I had just said, but this is different forms of anaphylaxis. These are the tests that you should look at. Again, I would get a baseline serum tryptase, I would get a baseline serum histamine, and a serum IgE level. And then if any of those are abnormal, like an elevated serum IgE level, a serum tryptase that's 6 or higher, or an elevated plasma histamine, it would be worthwhile for them to undergo further evaluation for mast cell activation syndrome. You've seen this slide already. My apologies. So again, going back to this well-fed cell that was identified back in 1877, the riddle of mast cells seems to be unfurling, such that we're trying to see that mast cells have a key role in homeostasis with defense, inflammatory response for tissue maintenance, blood flow coagulation, as well as reproduction. It seems that it is the epithelium that controls whether or not the mast cells will actually have differential secretion or degranulation. They also have a role in tissue repair as well. I can tell you that stress, whether it is comorbid disorder that's undiagnosed or even emotional stress, will exacerbate or unlock the mast cells to become more symptomatic. And in order to help these individuals, it is really a multidiscipline effect. It was Polly Matzinger who suggested a long time ago, this is not about whether you eliminate self-reactive T cells. It really is a dynamic system where if the tissue tends to be chronically stressed, you're not going to be able to induce tolerance. That's why with a lot of these patients, it is a team effect. We actually have a clinical social worker who's attached to our practice. We have a nutritionist to kind of act as a life coach regarding how to eat, what foods to help manage their diet. We have we work with sleep specialists to make sure that the sleep is well maintained and that they don't have disruptive sleep architecture as well. And if you're able to address the immune triggers or non-immunologic triggers, as well as address what might be driving the patient to be physically stressed and not having a large allostatic burden, you're able to help these patients come under control. and I will finish a little bit early to see whether or not I can address any questions or comments. But I do, again, appreciate the opportunity to speak to you. I miss being in-house, especially I have a fondness for Lloyd Mayer, who I've known for close to 15 years prior to his passing. But really, when it comes to seeing individuals that have mast cell disorders, you have to kind of take some risks and think outside of the box.
Thank you so much, Dr. Maitland. That was extremely interesting. I have a question in the chat from Dr. Itzkowitz, and he was asking, what is the relationship between peripheral eosinophilia and mast cells or mast cell activation syndrome? As we have noted that patients with Crohn's and eosinophilia tend to have a more severe course.
So eosinophils seem to be recruited in via mast cell dependent and mast cell independent ways. So we also know that mast cells have the ability to recruit via chemokines as well as interleukin-5. And so we find out that it is the mast cells that dictate the recruitment of other innate immune cells, whether we're talking neutrophils, and you mostly see that in individuals that have immunodeficiencies that are not diagnosed, or eosinophils. For instance, University of Cincinnati has shown that individuals that have connective tissue disorders are at increased threat having mast cell dysfunction, and this is in their patients that have a diagnosis of an eosinophilic gastrointestinal disorder. So we believe it is the mast cell that has helped recruiting and keeping the eosinophils in the tissue. And targeting the mast cell compartment or the mediators that are recruiting the eosinophils may be a way of reducing the burden of inflammation in that affected tissue.
Thank you.
Hi, Dr. Maitland. Bruce Sands here. I'm the chief of the division. It's nice
Hi,
to
Dr.
meet
Sands.
you.
Nice meeting you as well.
Yeah, that was such an eye-opening lecture. I think all of us probably can think of any number of patients who might in fact have a mast cell activation disorder or syndrome, people who just don't fit in any spectrum of other diagnoses, even though we're trying to force them into those diagnoses. So I really appreciate the outside perspective that I think we all really benefited from this lecture.
Thank you. I have to tell you, it really has to be a joint effort. I mean, that was the beauty about Mount Sinai, the very close relationship when, even in the infusion suite between allergy, immunology, and the gastroenterology division. And I find it interesting that the first paper identifying non-clonal mast cell activation syndrome was a joint effort between allergy, immunology, and gastroenterology. So we have to have this crosstalk. Otherwise, we keep those lenses on and don't take a look outside of that. And I'm happy if there's anybody that you want me to evaluate, I'm happy to do so. And what I'll do is I'll give you my email, just let me know, and I'm happy to show some input there. It's been a little bit of an effort to get the pathology department to do the staining for mast cells. If you don't use those stains, you will not light them up.
And actually, I do have a question about that. So the stains can be done on formalin-fixed tissue, or does it need to be fresh? Yeah, so in other words, if you don't think of it in advance of taking the biopsies and sending it in probably saline, right, you're not going to be able to do the staining.
Right. Like we had a patient, which is really interesting because we actually just submitted a paper. We had a patient who had scombroid poisoning. Her and her husband. Her husband was former faculty at Mount Sinai. And interestingly enough, she then developed chronic asthma, chronic urticaria after the poisoning. He was fine, and he had MS. And there's evidence of tissue injury. Think about what do we need to do to make mice develop IBD? We have to traumatize the epithelium. And by traumatizing the epithelium, you recruit in the mast cells. And depending on what type of trauma, whether it's a physical trauma, like the model for developing anaphylaxis in certain types of mice is you would do barotrauma. right? And then you would apply the allergen that you want it to become sensitive to. So the same thing about this dysregulation of the microbiome and perturbed epithelium that allows the recruitment of the mast cells. I mean, so literally, and so this is why I'm saying, I think in many ways, understanding the dynamics between the mast cells and the epithelium as it's dealing with this huge load, especially in the gastrointestinal tract, of foreign entities. Some of those you need, some of those you don't. How do you distinguish? So I really think this just opens up a whole new avenue of trying to understand not only irritable bowel syndrome, but potentially irritable bowel disease, IBD. Thank you.
Well, actually, there's a very strong thread of mast cell research in kind of the 80s, maybe even around there. Mast cells and eosinophils, their crosstalk within IBD research. And there was a kind of a, not a very dominant theory that was in circulation about sort of ulcerative colitis, especially being sort of asthma of the colon. And there were attempts, I think, even to use ketotifen to treat ulcerative colitis with some modest success. Of course, it's not available in the US, I believe.
Compounded, it is.
Is it compounded?
Yep. You can 1 milligram capsules can be compounded by any pharmacy that does compounding.
So it's part of the US pharmacopoeia?
Mm-hmm.
Okay.
Because it's available as an eye drop, so it's available as a powder. So then they can just take the powder and put it into vegetarian capsules. I
see. Otherwise, it's cromolyn, I guess, would be.
Exactly.
Which is quite expensive, I believe.
You know, it's funny. One of my colleagues is actually out of Germany, and it's over the counter as a powder that they can just add to water. It's so silly.
Not here.
I know. I'm like, what's so complicated? And it'll be interesting. It's an old medicine. I don't understand why it's so expensive. And it's actually cheaper to have it compounded, put into 100 milligrams per milliliter and give them and send it to the compounding pharmacy is $110 as opposed to individual vials. It's bananas. It really is.
Amazing.
I have another question. Are there
nice meeting you, Dr. Sands.
Likewise.
Are there specific areas in the GI tract that are higher yield for finding mast cells on biopsies?
Yes. So you really want to look at the small intestine and the colon. So duodenum is an excellent site to look at. I can send you the paper by Matthew Hamilton, who really has taken the lead with mast cell disorders in the gastrointestinal tract, and he only has a few papers. Actually, I think the paper I might have sent that I had emailed to Dr. David has the sections of the gastrointestinal tract where they have an average of how many mast cells, but it's not just the number of mast cells, it's also whether or not they're chronically activated. It's kind of like your police officer at the corner always having their gun out. And I'm like, can you please put that back in the holster? So mast cells, you don't want to see upregulation of CD25 or CD2, because that means they're chronically releasing chemical mediators. Which ones we don't know, but you want to count them. You want to see whether or not they're spindle shaped or circular, because if they're circular, they're resting. If they're spindle shaped, that's also diagnostic for a mast cell activation disorder as well.
Thank you. Do we have any other questions from the audience?
I think you left us dumbfounded.
Oh, that was terrific. Thanks so much.
Oh, my pleasure, Dr. Greenwald. Yeah, no, please. And you have my email. Feel free to ask, send questions to me. I have to tell you, it's been, there are a few gastroenterologists that I work with on a regular basis, and I appreciate them listening. So shout out to those who are listening. And again, I look forward to kind of forging a more cooperative relationship with the GI department.
That'd be great. Steve Itzquit says we're going to send you all of our IBS patients, but we really won't. So.
maybe you better tell us what we should do first before we send them to you, which I think you did.
No. It's honestly my question. I basically emailed a questionnaire to the patient beforehand. It's 20 pages. So,
Wow.
and then I read that along with any reports that are sent by the referring practitioner. And so we have at least some information to have a very productive conversation the first time I talk to the patient.
Great.
Wonderful. Thank you so much.
My
Thank you
pleasure.
so much for joining us.
Everyone stay
Thank you.
safe. Thank you again for the invitation.
Thank you.
Bye-bye.
Bye
Take
now.
care.